Good morning, everyone. Welcome to our presentation. I'm Tiffany Bradshaw. I'm one of our clinical product managers of chemistry and toxicology at ARUP. Today we have a great presentation. Our medical director, Dr. Gwen McMillin. She's our medical director of toxicology and pharmacogenetics. She's a member of our R&D executive committee and a professor of pathology at the University of Utah School of Medicine. Today, she's going to be discussing the importance of monitoring imatinib levels to help minimize therapy costs and prevent disease-associated medical expenses. Without further ado, here is Dr. Gwen McMillin.
Hey, good morning, everyone, and thanks for coming. So, as Tiffany said, I'm going to be talking about imatinib. If you happen to have catched the keynote plenary speaking yesterday, Dr. Brian Druker gave a wonderful presentation about imatinib and how it revolutionized the therapy of chronic myeloid leukemia, or CML, and some gastric stromal tumors, or GIST patients. And I'm going to be focusing on how monitoring plasma concentrations of imatinib can produce both medical and economic benefits to our patients. So as mentioned by Dr. Bruker, the imatinib mesylate, which was originally approved in 2001 under the brand name Gleevec, was the first tyrosine kinase inhibitor, and it's used to treat CML and GIST. It essentially works by competing with ATP, binding to tyrosine kinases, such as BCR-ABL in CML, and c-KIT and PDGFR in GIST tumors. And so in doing so, it's very targeted and prevents continuation of the tyrosine kinase activity. So besides the phenomenal efficacy of this drug, two of the other characteristics that make it very successful are, first, the convenient dosing. So it's an oral formulation that can be administered at home, either once or twice daily, which is very nice because treatment is often lifelong. Another characteristic of imatinib that makes it very successful is that it has a favorable safety profile. So side effects are relatively minimal. And just recently, imatinib came off patent, and so there are now a number of generic formulations available, which is probably renewed interest in imatinib because we can reduce costs of therapy while optimizing dose. So as mentioned, imatinib is a targeted therapy, and so it's going to work best when the disease being treated will respond to that target. But in addition to that, imatinib doesn't work for everybody. And like most drugs, there are a number of factors that can influence whether or not that drug is successful. And most of these are associated with pharmacokinetics. Imatinib has near complete bioavailability, so that's not a problem. But metabolism and elimination kinetics are variable with this drug and can be influenced by the dose, age, gender, genetics, the formulation, as well as any co-medications, which of course is going to change over the lifetime of a patient. All of these characteristics are illustrated by looking at the relationship between drug concentrations and time, as illustrated by this plot. So the idea is to understand how the concentration relates to time, and then also understand how the drug concentration relates to efficacy and toxicity. So if we can establish a therapeutic window, then we can target what dose an individual patient should be taking to optimize efficacy and minimize side effects that are dose-related. Another important characteristic of therapeutic success is adherence. It makes pretty good sense that you have to take the drug if it's going to work. So all these characteristics fall into a category of laboratory services called therapeutic drug monitoring, or TDM. TDM is most beneficial when drugs exhibit a good relationship between the blood concentrations and response, both desirable and undesirable responses. It's also beneficial when the drug exhibits wide range of concentrations from the same dose, which is primarily due to changes in pharmacokinetics. TDM is beneficial as well for drugs that have very high cost and for which adherence is a problem. And in fact, adherence is well recognized as an issue with chronically administered medications. So over the next few slides, I'm going to go over some of these factors and data to support why I think imatinib is a great candidate for TDM. So as a reference laboratory, ARUP has a lot of unique samples, and I wanted to get a kind of a snapshot on what the range of concentrations for imatinib looks like in our population. And so we took a series of samples that were submitted for BCR-ABL testing, so CML patients, and then looked for imatinib concentrations. And this plot shows you the distribution of concentrations for about 230 patients. So I've plotted imatinib on the y-axis against age, and then the color of the dot represents the gender. And so what you can see is that with this snapshot of real-time samples, concentrations range several orders of magnitude, so roughly 300 to 3,000 or 4,000 nanograms per mil, and that there was not really a significant correlation between gender or age and concentration. But certainly if we can understand how these concentrations relate to efficacy and toxicity, we can guide dose selection. One of the concerns, however, with this data set, because it was a random selection of samples, we had no clinical information about those samples. And so we don't know if all these low concentrations reflect non-adherence or early time points or pharmacokinetic variability. So we looked into the literature to provide some insight as to that. This is data from a study wherein adherence was evaluated using a microelectronic device, and in a number of patients treated with 400 milligrams per day of imatinib. And what you can see very clearly in this plot is that those patients that were adherent with 90% or more of their doses had a much higher probability of the desirable response, which in this case is major molecular response, indicating a 3 log reduction in the BCR-ABL transcript. And on the other side, patients that are non-adherent are not likely to respond. So this is one good reason to pursue TDM, is to find out whether patients are adherent or not. Certainly if we get a very, very low value, that would suggest non-adherence. But if we see a positive level, it's hard to know exactly what that means. And so I looked into some of the studies that have been published. This one was actually published by Dr. Richard Larson from University of Chicago, wherein the imatinib and norimatinib concentrations were evaluated at day 1 of therapy and at day 29 of therapy. And so this was an international study and showed basically that the norimatinib is present at much lower concentrations than the imatinib. So it's not extensively metabolized. The imatinib concentrations varied almost twofold between 1 day and 29 days. So a low value that stands alone, you really don't know if the person has taken the drug regularly or not. So this makes the case for serial monitoring. It's also noteworthy that the standard deviation is very high, and that there were some trends in terms of slightly higher concentrations in women, slightly lower in body size, and it's thought that those two explain one another. And then slightly higher concentrations with increasing age. And so again, I think these data make the case for serial monitoring, so you can observe changes over time, understand what the optimal concentration is for an individual patient relative to response. And then, of course, adjust for changes in pharmacokinetics that occur with age or co-medications. So this same data set was evaluated relative to the 29-day concentrations, which should be at steady state, and divided into quartiles. So you can see those quartiles delineated here. They then looked at the relationship between these concentrations and response, combining the second and third quartiles as the central 50%. And you can see that data summarized here, where at 1 year, 2 year, and 5 years, there's a clear difference in terms of the percent responders relative to concentration. And so increasing concentration means a higher proportion of response. And statistically, the pre-dose or C-min, sometimes called a trough concentration of greater than 1,000 nanograms per mil was statistically associated with improved response. And so this has been proposed as a therapeutic threshold. There are a lot of other studies that support this, such as this data from the TKI optimization and specificity study, or TOPS study, that was published a few years later. But the data illustrated the same way here, where we have quartiles of patients based on the concentrations. And then here they looked at rate of response for 2 different categories of response: the major molecular response, or MMR, that I mentioned before, and then also complete cytogenic response, which reflects no CML cells detectable. And so that being a little more stringent criteria, the overall percentage of response varies a little bit. One of the things that was very interesting in this study is that they randomized patients to either 400 or 800 milligrams per day, and clearly there's a good dose relationship where with that, because most of the lower concentrations in the first quartile, most of those patients were on 400 milligrams per day, whereas most of the patients in the upper quartile were on the 800 milligrams per day. And from this study, they found a consistent conclusion with the previous study in that the C-men at the threshold between quartile 1 and 2 was statistically associated with improved response. So this study evaluated patients with the gastrointestinal stromal tumors, or GIST. There aren't as many studies done with GIST patients, but it showed a very similar response in terms of the fact that patients at the mid and upper quartiles responded best. This was an interesting study in that they separated out patients based on the primary mutation in the c-KIT tyrosine kinase gene, and found that the most common c-KIT variant in exon 11 actually was most sensitive to the imatinib. So having a higher concentration was very effective in that population, and the authors actually suggested for other mutations which were not as prevalent in the study that perhaps 800 milligrams would be more appropriate. But nonetheless, a therapeutic target of greater than 1,100 nanograms per mil was statistically associated with the improved response. There was also a nice study published wherein the authors generated a receiver operator curve, or ROC curve, as you can see on the top panel in this graph. With the concentration that yielded the best sensitivity and specificity was 1,002 nanograms per mil. And you can see from the plot below, the box plot, that nearly all the patients with the major molecular response had concentrations above 1,000 nanograms per mil, whereas nearly all the patients that did not respond had concentrations less than 1,000 nanograms per mil. So there were subsequently some studies that have applied that information, so using a concentration threshold to make decisions about dosing. This is data from one published by Dr. Pierre Rousselot, wherein they took newly diagnosed CML patients and then measured the plasma concentrations originally at day 15 and then about monthly thereafter, and adjusted dose for a portion of those based on the concentration. And this summarizes the overall response, where the percent of patients that responded was much larger in those that received personalized dosing than those that got standard treatment. So almost twice as many patients responded when they got the personalized dosing. And surprisingly, the range of concentrations associated with dose was variable enough that only about a third of patients were managed well on 400 milligrams a day. So 2/3 of patients had to have their dose adjusted, either lowered or higher. Most of them were higher doses. And so one of the conclusions from this study was that perhaps 600 milligrams is a better dose for most patients. Now, it's really great to control efficacy with dose, but we also get concerned about adverse events that might be dose-related. And the most common adverse events with imatinib are fluid retention or edema, rash, myalgia, and anemia. And while there have been some trends relative to adverse events, none have achieved statistical significance. And so the correlation of imatinib plasma concentrations with adverse events is very inconsistent, and there's no toxic threshold that is well recognized at this point in time. That said, there's no reason to give people excess dose if they don't need it. So there are a number of medical reasons as to why imatinib monitoring makes sense. So first of all, to optimize dose, which would maximize efficacy and decrease the likelihood of toxicity. We also know that TDM is likely to improve adherence, just because if you're watching and the patients know they're going to be tested, they're more likely to take their drug. TDM is also extremely useful in a longitudinal manner for identifying changes in pharmacokinetics, which could be a result of polypharmacy, so drug-drug interactions, pharmacogenetic variability, comorbidities, changes in disease status, and age. And then finally, one of the benefits of imatinib is that it can be useful for evaluating when disease progresses or relapses. So the common reason for a relapse or a progression of disease might be that additional mutations have been have developed in the cancer. But another important reason might be inappropriate dosing or poor adherence. So looking at blood concentrations is an extremely valuable part of that workup. There are also some economic arguments as to why TDM for imatinib makes sense. Obviously, if a patient needs a lower dose, then we can reduce the costs of drug therapy. These drugs are very expensive, so the less you have to take, the lower the burden on the patient for those expenses and the healthcare system in general. We also know that improved adherence will reduce the likelihood of therapeutic failure. That if we reduce the likelihood of therapeutic failure, we can reduce the costs of therapy. Now that there are several generic formulations of imatinib available, we can also reduce overall costs versus when compared to some of the second or third generation tyrosine kinase inhibitors. And in fact, in some parts of the world, the cost of the generic imatinib is a very small fraction of the cost of the brand name. So this is something that's very relevant from an economic perspective. By triaging patients and only putting them on those second or third generation medications that are a lot more expensive, we can also minimize costs. So start people with imatinib and then only go to the next generation if required. So there are some recent studies that have tried to evaluate this. There aren't so many prospective, but this is one of the pharmacoeconomic studies I'm aware of that was presented earlier this year. And so in this case, the model was built to treat all patients with 400 milligrams a day of imatinib, and then evaluate whether or not the patient is tolerant or intolerant of the medication. If they're intolerant, then looking at the concentrations, and in this case, a toxic threshold of 1,600 nanograms per mil was applied, such that if a patient had concentrations greater than 1,600 nanograms per mil, they would get a dose reduction to 300 milligrams. If it was less than 1,600 nanograms per mil, then it suggests that imatinib is just not a good fit in that particular patient, and so the course of action would be to prescribe a second-generation drug. If, on the other hand, the patient tolerates the imatinib well, then the decision-making process depends on whether the person responds. So if they respond, great, no need to do anything. If they do not respond, then let's look at the concentrations. And if concentrations are either less than 1,000 milligrams per mil or greater than 1,600 nanograms per mil, then we're going to act by either dose escalation or transferring that patient to another TKI. So this model was utilized with a number of published percentages and simulated in 1,000 patients. And the outcome of that simulation is shown here, where the total cumulative cost and quality adjusted life years were estimated and were demonstrated to improve. So lower cost overall and higher quality of life in patients with the TDM. That was at 5 or 10 years. It's interesting that the lifetime cost actually increases a little bit, as does the quality adjusted life years, but the rationale for why the cost would actually increase is just because the patients are living longer and so are more likely to have other types of expenses. But in general, the conclusion was that TDM for imatinib therapy will improve efficacy, improve lifespan, and reduce costs. Another study that was presented earlier this year, well, actually late 2017, looked at the cost of therapy as well. And in this case, there was a couple of differences from the previous study. One was that the previous study estimated adherence at about 86%, and this study estimated adherence at about 75%, which is similar to the study that I showed you in the beginning of this presentation. The other is that the frequency of TDM was higher in this study than in the previous study. And that this study looked at two different sources of drug costs, one from the Federal Supply Schedule and one from the wholesale acquisition cost, where the previous study looked at REDCap for costing. But in any case, you can see as bolded on this slide that the costs of therapy with TDM were significantly lower than without TDM, or when compared to a second-generation drug such as dasatinib or nilotinib. So hopefully I've convinced you that there are medical and economic reasons to do TDM for imatinib. And ARP Laboratories has just launched a test for supporting that application. To minimize the turnaround time, get results back faster to you, we started out with by offering this as an immunoassay. So it's a laboratory-developed test based on immunoturbidimetry. Our analytical measurement range is 300 to 3,000 nanograms per mil. And we compared results in authentic patient samples using two different LC-MS methods from outside of ARUP. And as you can see from the plot here, we had very good correlation. We recommend collecting a pre-dose or Siemens specimen with potassium EDTA or lithium heparin at either 29 days after therapy has been initiated, so presumably steady state, or at least 8 days after a change in therapeutic dose. Then you send the plasma and we get results out. So in conclusion, the clinical efficacy of imatinib is well established. There is now a test available, and that test can be used to identify variable pharmacokinetics. It can improve patient care by optimizing dose, monitoring adherence, evaluating resistance of therapeutic failure, and minimizing costs of therapy. And so finally, I just want to acknowledge the other people at ARUP that were involved in bringing this test on and validating it, as well as our colleagues from Huntsman Cancer Institute that were able to acquire authentic patient samples for us. And then the two laboratories that helped us with the LC-MS comparison, Oregon Health Sciences University and University of Pittsburgh Medical Center. So thank you for your attention, and we'll take any questions you may have.